Fabry disease is a rare X-linked genetic disorder characterized by the deficiency or dysfunction of the enzyme alpha-galactosidase A, alpha-Gal A, leading to the progressive accumulation of glycosphingolipids, particularly globotrosylceramide, GB3, in various organs and tissues. This accumulation results in a wide range of clinical manifestations, including cardiovascular, renal, neurological, and ocular abnormalities. In this script, we will explore the complex pathophysiology, clinical features, diagnostic challenges, and management strategies of Fabry disease. Fabry disease is inherited in an X-linked recessive manner due to mutations in the GLA gene. This gene encodes alpha-Gal A, an enzyme involved in the breakdown of glycosphingolipids. Mutations in GLA lead to reduced or absent alpha-Gal A activity, causing the buildup of glycosphingolipids in lysosomes. This accumulation damages cells in different organs, resulting in the symptoms seen in Fabry disease. Patients with Fabry disease commonly experience episodic burning and tingling sensations in the hands and feet called acroparesthesias. Other clinical manifestations include angiokeratomas, small, dark red or purple skin lesions, and gastrointestinal symptoms like abdominal pain, diarrhea, and early satiety. The pathophysiology of Fabry disease is primarily driven by the progressive accumulation of GB3 in multiple organs and tissues. The entrapment of GB3 within lysosomes disrupts normal cell function and leads to cellular injury and death. This process affects various systems, including the cardiovascular, renal, neurological, and ocular systems. The exact mechanisms underlying the tissue-specific effects of GB3 accumulation are still the subject of ongoing research. Cardiovascular manifestations are a hallmark feature of Fabry disease. Left ventricular hypertrophy, LVH, characterized by an increase in the thickness of the left ventricular wall, occurs in the majority of affected individuals. Over time, LVH can progress to cardiomyopathy, which impairs cardiac function. Valvular abnormalities, such as mitral insufficiency and aortic stenosis, may also develop. These cardiovascular complications significantly contribute to morbidity and mortality in Fabry disease. Renal involvement is a common feature in Fabry disease, with progressive kidney damage being a major cause of morbidity and mortality. Proteinuria, particularly the presence of microalbuminuria, is often an early sign of renal involvement. Over time, renal function declines, leading to progressive renal impairment and ultimately end-stage renal disease, ESRD. Renal replacement therapy, such as dialysis or kidney transplantation, may be necessary in advanced cases. Neurological complications in Fabry disease can be diverse and debilitating. Ischemic stroke and transient ischemic attacks, TIAs, are significant concerns due to the progressive cerebral vasculopathy observed in patients. White matter lesions, identified through imaging studies, are commonly observed and can contribute to various neurological symptoms, including neuropathic pain, cognitive deficits, and cerebral dysfunction. Early recognition and management of these neurological complications are crucial to prevent long-term disability. Fabry disease can affect the eyes, leading to several ocular manifestations. Corneal and lens opacities, visible upon clinical examination, can cause visual disturbances. Additionally, retinal abnormalities, such as vascular tortuosity, dot and fleck retinopathy, and macular changes, may be present. Regular ophthalmologic evaluations are essential to monitor and manage these ocular manifestations effectively. Enzyme replacement therapy, ERT, has revolutionized the management of Fabry disease. ERT involves the intravenous infusion of recombinant alpha-Gal A enzyme, which helps to normalize the enzyme levels and reduce the accumulation of glycosphingolipids in various tissues. ERT has shown significant clinical benefits, including improvements in pain, renal function, cardiac parameters, and overall quality of life. Regular and lifelong administration of ERT is typically required for optimal outcomes. Although ERT has transformed the management of Fabry disease, it does have its limitations. ERT does not effectively cross the blood-brain barrier, limiting its impact on neurological complications. Moreover, it requires lifelong intravenous infusions, posing logistical challenges and potential complications. Emerging treatment strategies, such as chaperone therapy and gene therapy, hold promise in addressing these limitations and providing more targeted and convenient therapies for Fabry disease. Given the genetic nature of Fabry disease, genetic counseling and family screening are crucial components of its management. Genetic counseling helps patients and their families understand the inheritance pattern, recurrence risks, and available screening options. Identifying affected family members early allows for timely interventions, including genetic testing, diagnostic evaluations, and initiation of appropriate therapies. Diagnosing Fabry disease can be challenging due to its wide range of clinical manifestations and the overlap of symptoms with other conditions. The rarity of the disease and limited disease awareness among healthcare professionals further contribute to diagnostic delays. Heightened clinical suspicion, proper utilization of diagnostic algorithms, and collaboration with multidisciplinary teams specializing in rare diseases are essential for the early and accurate diagnosis of Fabry disease. The long-term prognosis of Fabry disease is dependent on various factors, including the severity of organ involvement, age at diagnosis, and access to appropriate interventions. Without treatment, Fabry disease can significantly impact quality of life and lead to premature death. However, with early diagnosis and timely intervention, the prognosis can be significantly improved. Initiating treatments such as ERT and addressing the disease's multisystemic manifestations can enhance outcomes and potentially prolong the life expectancy of affected individuals. In conclusion, Fabry disease is a complex disorder caused by GLA gene mutation, resulting in alpha-GALA deficiency and accumulation of glycosphingolipids in organs. Diagnosis requires suspicion and genetic testing. ERT has improved management, but challenges and emerging treatments persist. Family screening and counseling are crucial. Early detection and intervention improve long-term prognosis. Awareness and early detection are vital.